Good day, everybody. This is Dr. MGoenka. I'm presently the Director of Gastroenterology and Liver Diseases at Apollo Clinicals Hospital, Kolkata, also the President-elect for Indian Society of Gastroenterology and Governor of Indian Region for American College of Gastroenterology. I'm happy to take you through this brief but exciting session on gastroenterology and hepatology. We have carefully chosen three very important and emerging diseases to be discussed in this session. And we have selected three eminent personalities from all over the world to deal with these subjects. Equally eminent personalities will be chairpersons for all the three talks, which we are going to hear shortly. To introduce the first chairperson, we have Dr. Deepak Patkar, who is the Director of Medical Services in the Department of Radiology at Nanavati Super Specialty Hospital, Mumbai. He is currently the President of Indian Radiological and Imaging Association. He was trained in California and Cornell University in New York. He has received Best Radiology Teachers Award for 2019 at Radiology and Imaging Conclave and has delivered more than 1,000 lectures and orations in various national and international conferences. I would invite Dr. Deepak Patkar to introduce our first speaker, Dr. Nageshwar Reddy. Audience have the chat box where they can type their questions with their name as well as the email ID. And I promise that within a week of the conference, these questions will be answered.
Thank you, Dr. MGoenka, moderator of the session, for my kind introduction and inviting me to introduce a very renowned speaker, Dr. Nageshwar Reddy. I am also thankful and grateful to Global Association of Physicians of Indian Origin for giving me an opportunity to chair the session during this Global Indian Physicians Congress. It's a great honor to introduce Dr. Nageshwar Reddy. He is the chairman of Asian Institute of Gastroenterology and AIG Hospitals at Hyderabad. Dr. Nageshwar Reddy is the past president of World Endoscopy Organization. The main area of research interest of Dr. Nageshwar Reddy has been in GI endoscopy, particularly in therapeutic pancreatico-biliary endoscopy and innovations in transgastric endoscopic surgery. Dr. Nageshwar has published over 670 papers in national and international peer-reviewed journals and has contributed chapters in 20 international textbooks of gastroenterology and has edited 8 GI endoscopy textbooks. Dr. Nageshwar is on the editorial board of Gastrointestinal Endoscopy, Digestive Endoscopy, World Journal of Gastroenterology, World Gastroenterology News, Gastroenterology Today, recent patents on medical imaging, and gastrohep.com. Dr. Nageshwar is the peer reviewer of the journals like Lancet, Gastrointestinal Endoscopy, Endoscopy, and Hepatology and Indian Journal of Gastroenterology. Dr. Nageshwar has been conferred with Dr. B.C. Roy Award in 1995, Padma Shri Award in 2002, and Padma Bhushan Award in 2016. It's a great honor for me myself to introduce Dr. Nageshwar Reddy. Can I now request Dr. Nageshwar Reddy to deliver his talk on what is new in endoscopy? Thank you.
I'd like to thank Gapio for this opportunity.
Deepak Patkar for
moderating this session along with Dr. MGoenka. Gastrointestinal endoscopy has revolutionized the treatment of many gastrointestinal disease. There's large amount of advances that have occurred in this area, but for lack of time, I'm going to concentrate on 3 areas. Gastroesophageal reflux disease would be the first one. We know that many patients with gastroesophageal reflux disease that the physicians treat are treated with long-term PPI. But unfortunately, long-term PPI have many side effects, and many of these patients do not want to take these medicines for long. Plus, some of them have refractory GERD, which do not respond to PPI. Of course, surgery is an alternative, but they want to avoid surgery, especially when they have a volume reflex. The only other alternative in these patients is an endoscopic anti-reflex therapy. An endoscopic anti-reflex therapy has now evolved so that we have several techniques and technologies to treat these patients. We have anti-reflex mucosectomies, we have radiofrequency ablation, and variety of things. For example, very simply, we can do an endoscopic anti-reflex mucosectomy, create a new valve in these patients. And similarly, we are starting to do this GERD-X procedure, and recently from our institute, we have demonstrated by doing this GERD-X technique where we can do endoscopic stapling to actually stop reflux from occurring, decreasing the G junction caliber. So these are new techniques and technologies that are coming now, and they will certainly replace surgery so that many patients who require long-term PPIs can be treated by this method without the need for PPI. The second technique that's going to come is going to be duodenal mucosal resurfacing. This is very interesting because we know that patients with diabetes, obesity, and non-alcoholic fatty liver disease, hypertriglyceridemia, and also have metabolic syndrome. And treating metabolic syndrome at present is extremely difficult. It's become an epidemic in our population now. Earlier, we used to think that the central control of this whole metabolic process was in the pancreas. We now know that the pancreas is no longer responsible for this. It's actually the second part of the duodenum which controls the whole metabolic systems in the body. And based upon what we have knowledge of this, we have started now doing what is called the duodenal mucosal resurfacing, where we can put an endoscope into the second part of the duodenum, resurface the mucosa of the duodenum so that the duodenal mucosa is completely taken off with thermal hydrotherapy. And then following this, the new mucosa which comes is completely new, does not contain the neurohormonal complexes that are present in the older mucosa, and therefore a new thermostat is set in these patients so that metabolic syndrome obviously disappears. And this is some very interesting data that's coming in with this. We have found that you actually can get a good glycemic improvement in these patients once we do DMR. In many of these patients, we can take them off insulin, we can take them off oral anti-diabetic agents, and soon I think endoscopy is going to become one of the most important way to treat patients with type 2 diabetes who are not responding to standard treatment. So we now know that, for example, that the duodenum has a metabolic role, and the physiological role is in terms of insulin resistant signal that come from this. In patients who have abnormal metabolism, especially diabetes mellitus, fatty liver, and so on, there's evidence of hypertrophy, hyperplasia in the upper GI mucosa, and these can now be corrected by using an endoscope by actually ablating this duodenal mucosa. So some very exciting endoscopy therapy coming. And finally, another area where there is a lot of new endoscopy therapies are coming in is in the area of third space endoscopy. This is, for example, for treating with patients with achalasia cardia. Patients with achalasia cardia can have obstruction in the lower part of the esophagus. This is a functional obstruction. And generally, they're treated either with a balloon dilatation or with Heller's laparoscopic myotomy. But we now have a new technique called POEM, which is called the peroral endoscopic myotomy, which can treat these patients very adequately. For example, we make a small opening in the mucosa endoscopically, cut the muscular layer, and then close it off. So this is a procedure which is just like Heller's myotomy. The only difference is that the patient doesn't have any scars, can even be discharged on the same day. It becomes very simple. And there's a dramatic response to treatment in many of these patients. And a recent trial published in New England Journal, which compared Heller's myotomy, the standard technique with POEM, has shown clearly that POEM is superior to Heller's because it's less invasive, lower amount of adverse side effects. The small number of patients who have esophagitis can be treated with PPIs or one of the endoscopy techniques that I showed you. So you see, because of this third space endoscopy and POEM that has come in, many of the surgical conditions have become endoscopic conditions. That is, there are no more surgical disease. Achalasia, subepithelial tumors, refractory gastroparesis which is seen in patients with diabetes, Hirschsprung disease, and esophageal strictures. All of them are now can be treated without the need for surgery. So endoscopy is now going to play a major role, take over many surgical diseases in future. And these are 3 examples I just showed you. But again, to show you something more radical that's going to happen, this is just a cartoon which suggests that now endoscopically we can do things much more than what we thought before. This is a patient who has severe abdominal pain. So we use a capsule endoscope, and that shows that there's acute appendicitis. The images are transmitted to the concerned doctor, and then the doctor can be transported to the patient's house. And again, without the need for surgery, we do what is called the NOTES procedure, natural orifice transluminal endoscopic surgery, where you can make a small opening in the stomach, go in through the peritoneal cavity, and then there's the inflamed appendix there. We're already doing that now in regular practice, and this appendix can be removed through the mouth, and the patient can stay back in the home. So these are the dramatic advances that are occurring in gastrointestinal endoscopy, and I'm sure that many of these will be available very routinely to patients whom you see in clinical practice. Thank you very much.
I must thank Dr. Deepak Patkar and the speaker, Dr. Nageshwar Reddy. In a brief 8 minutes presentation, he has told us about 3 emerging technologies in the field of endotherapy of gastroesophageal reflux disease, the role of duodenal resurfacing for treatment of obesity and as a part of the metabolic endoscopy, and has also introduced now almost established technique of POEM for the management of achalasia cardia. I will now move forward and introduce you to the next chairperson, Dr. Rohini Sridhar. Dr. Rohini is Chief Operating Officer at Apollo Hospitals Madurai and is also the Joint Secretary of GAPIO. She is also the member of the core group of GAPIO's Women's Forum. She'll introduce our second speaker, Dr. Arun Sanyal.
Thank you, Dr. Mahesh Goenka, for those generous words of introduction. I'd also like to thank GAPIO for giving me this opportunity to chair this session on gastroenterology and hepatology. It is my proud privilege to introduce the speaker for the next talk, that is Dr. Arun Sanyal. Dr. Arun Sanyal is a professor of medicine, physiology, and molecular pathology at Virginia Commonwealth University School of Medicine at USA. He has published more than 400 papers, of which 127 are in high-index journals. So this gives him an impact factor, which according to a Stanford University study, puts him in the top 0.1% of scientists. Dr. Arun was the past president of the American Association for the Study of Liver Disease and the founding member of the Liver Transplantation Board and chair of the National Institute of Health Liver Study Section and the NIH-NASH Clinical Research Network. Dr. Arun has been conferred the Distinguished Achievement Award by the American Association for Study of Liver Disease and the American Liver Foundation. I now invite Dr. Arun Sanyal to give his presentation. Thank you.
Thank you for the kind introduction. My name is Arun Sanyal, and I will talk to you today about non-alcoholic fatty liver disease. Here are my conflicts of interest. Non-alcoholic fatty liver disease, or NAFLD, is the most common form of chronic liver disease in the Western world and is rapidly becoming a very common cause of liver disease around the world. It has 2 principal forms. First, it may be characterized by accumulation of fat in the liver, but not much else, which is called non-alcoholic fatty liver, or NAFL, or it can present as a lesion called steatohepatitis, which includes 3 specific types of findings. First, accumulation of fat in the liver, which then leads to injury, which manifests itself in the form of a lesion called hepatocellular ballooning, and this leads to inflammation within the lobules of the liver. And this is called non-alcoholic steatohepatitis. Both NAFL and NASH are included in the umbrella term non-alcoholic fatty liver disease. So steatohepatitis is the more aggressive form of this lesion and can lead to cirrhosis with greater certainty than non-alcoholic fatty liver, and therefore is the lesion of greater public health interest. In considering the liver disease, there are two critical concepts to remember. First, the concept of disease activity, and the concept of disease stage. Disease activity refers to all of the biological processes that are trying to convert a normal liver into a cirrhotic liver. And this is seen under the microscope in the form of the severity of the steatosis, the severity of the ballooning, and the severity of the inflammation. And those are the classic histological markers that also correlate with metabolic perturbation, hepatocellular injury, and the response to the injury, which is inflammation. The consequence of disease activity is scarring of the liver or fibrosis. And this is identified by the fibrosis stage. Fibrosis stage represents proximity to cirrhosis, and liver outcomes occur once you get cirrhosis. So fibrosis stage tightly correlates with the long-term prognosis of the patient because it represents the proximity to cirrhosis. This is shown in the next slide. Here are data on the left from a prospective study of almost 1,800 patients that we followed for 8,000 patient years, and recently presented this data at the American Association for Study of Liver Diseases, where, as you can see, the mortality increases in a stepwise manner as we go from stage 0 to 2 to stage 3 to stage 4, which is cirrhosis. And what you see on the right are the rates of liver outcomes in those with cirrhosis, which is stage 4, bridging fibrosis, which is stage 3, compared to earlier stages. And as you can see, most of the clinical outcomes occur in the context of stage 3 and 4 disease, which are the critical stages of this disease. Now, fatty liver disease does not occur in a vacuum. It is closely associated with a number of other conditions, such as hypertension, heart failure, type 2 diabetes, chronic kidney disease, coronary artery disease, etc. These are all interlinked conditions, the root cause of which is metabolic stress with systemic inflammation and fibrosis, often having a link with diet-induced obesity. And even in lean individuals who have this condition, there is excess intra-abdominal adiposity, and biochemically, most of them have features of insulin resistance, particularly in adipose tissue, something we call adipose IR. So all of these pose competing risks and threats to life. So the first step in considering how to de-risk the patient's life is to first consider the possibility that all of these end organs are affected when you see a patient for any one of these end organ diseases, and paying attention to all of these different conditions by blood pressure control, managing atherogenic risk, vascular inflammation, diastolic dysfunction, paying attention to the QTc interval, preserving beta cells, and stabilizing GFR with existing medical therapeutics is a fundamental first step. Now, from a liver-specific point of view, we really need to also think about treating the root cause, which of course benefits all of the end organs that are affected by this cascade of biological events. Now, this is a schematic of how we should be thinking about the liver disease. Really, stage 2 and 3 disease is when outcomes start increasing. And then, of course, once you get to cirrhosis, you're closest to outcomes. Cardiovascular and renal outcomes are increased throughout the course of the disease and do not necessarily fluctuate that much, whereas liver-related outcomes occur pretty much once you have advanced fibrosis. So in this setting, the treatment options again include weight loss, saroglitazar, vitamin E, obeticholic acid, and GLP-1 agonists. The way we approach this, how do you identify this population that needs to be treated? And some simple tools have now emerged that can be used. So here are data from a large cohort study that we recently presented at the American Association for Liver Disease using a test called FIB4, which is based on age, AST, ALT, and platelet count. The formula is a little complex, and if you plug these numbers in to a FIB4 calculator, which you can find on your handheld by just going to Google and putting FIB4, you will get a number. If the number is less than 1.3, we classify them as class A. If it is more than 2.6, we put them in class C. And as you can see, the outcome per 100 person years progressively rises as you go from class A to B to C. Liver events increase, cardiovascular events increase, and hepatocellular carcinoma events increase. And on the right is shown the relationship between FIB4 and mortality as a continuous variable. So something as simple as just getting a hepatic panel and a blood count can allow you to assess the prognosis of your diabetic patient or cardiovascular patient or even your regular patient in a general clinic in terms of whether they might have fatty liver disease and how scarred their liver is and whether they are at risk. Because the liver is a very forgiving organ. It will not tell you something is wrong until things are very advanced. And you do not want to wait till somebody has cirrhosis and is decompensated before trying to identify their liver disease. The other tool that has become very popular now is the FibroScan, which is widely available. And as you can see, the FibroScan can be used to identify the presence of excess fat in the liver through something called the continuous attenuation parameter, which gives you a positive predictive value of over 90% with a cutoff of 260. So these tools allow us to identify excess fat and excess fibrosis. FibroScan can also identify liver stiffness and also help corroborate the findings of FIB4. Now, once you've identified people who have excess fat and increased liver stiffness, that is, their liver stiffness is over 8 or 9, or their FIB4 is over 2, then in those patients, the therapeutics that you can potentially use for which there is evidence include PPAR activators such as pioglitazone, saroglitazar, which is now approved in India, GLP-1 agonists such as liraglutide and semaglutide, for which there are data. Obeticholic acid is, I'm putting it in the list over here because it was one of the first agents to actually show improvement in fibrosis and is currently in a phase 3 trial. It did not get accelerated approval, but the study is still ongoing, and the data looks like it does actually improve fibrosis. So particularly for those who have substantial fibrosis, this may be an attractive choice. The main issue is making sure that the dosing is correct and you use a lower dose in people with cirrhosis. And then there's some data with vitamin E in retrospective studies showing that there is reduced liver-related outcomes in those with cirrhosis. And of course, in earlier stages, it has been shown to improve steatohepatitis. So here is the current paradigm for treatment of NASH in the context of metabolic syndrome, where at the time of the initial diagnosis, you assess all of the end organs. You start with weight loss, physical activity, statins and fibrates versus saroglitazar for improving the cardiothrogenic risk profile, use SGLT2 inhibitors and GLP-1 agonists as indicated, depending on if they have type 2 diabetes or not. And then after a period of time of 6 to 12 months, reassess the patient. And if they still look like they have significant residual disease, then liver-related therapeutics such as vitamin E, saroglitazar, OCA, and GLP-1s, further GLP-1s can be considered, particularly for those who have F3 disease or early compensated F4 disease. And we have to continue to enhance healthy living and stop some of these weight loss medications at this point. And finally, you have to reassess the patient to make sure that you're actually making progress. Because the ultimate goal is to improve mortality, reduce healthcare cost, improve the functionality of the patient and quality of life. I thank you for your attention.
Thank you, Dr. Rohini Sridhar. And I must thank Dr. Arun Sanyal for covering the vast topic of NAFLD, fatty liver disease, from the epidemiology to the concept of pathogenesis and the modern management. Thank you, Dr. Sanyal. Now, it is my pleasure to introduce Dr. Sudhakar Jonalagadda. Dr. Jonalagadda is American board certified in internal medicine and gastroenterology and is practicing currently in Georgia, USA. He is also currently the president of American Association of Physicians of Indian Origin, API. Dr. Sudhakar, please.
Greetings. I want to thank Dr. MGoenka for his kind introduction. And also I want to thank Gapio for giving this opportunity to chair this session of gastroenterology and hepatology. It is my honor to introduce today's speaker, Dr. Paul Tolwat. Dr. Paul Tolwat is the medical director of the Institute of Digestive Health and Liver Diseases at Mercy and serves as the director of University at Maryland Advanced Hepatology Network, director for Center for Liver and Biliary Diseases, and chief of gastroenterology at Mercy Medical Center, Baltimore. Dr. Paul is a clinical professor of medicine at the University of Maryland of Medicine, Baltimore. Dr. Tolwat has held various senior leadership positions, including medical director of liver transplantation medicine before his current position. Dr. Tolwat has published peer-reviewed papers and book chapters and edited 6 textbooks and has served on the editorial board of numerous journals. Dr. Tolwat has specialized interest in liver transplantation and has a research interest in liver transplant outcomes. Please welcome Dr. Tolwat. Thank you.
My name is Paul Tolwat. Today I'm going to discuss some of the latest developments in hepatitis B that were presented at the recent AASLD meeting. I wish to thank Dr. MGoenka and Chairperson Dr. Sudhakar Jonalagadda for asking me to give this presentation. So we all know that hepatitis B is a very common infection. Worldwide, 500 million people are infected with hepatitis B. And hepatitis B is a cause of death in about 500,000 people worldwide. It is a DNA virus and is also an oncogenic virus, meaning it can cause cancer. And hepatitis B is the most common cause of liver cancer worldwide. Being a DNA virus, it gets integrated into the host genome very early on after infection. So it is extremely difficult or almost impossible to cure hepatitis B. Once you get hepatitis B, it's a lifelong disease. Many investigators were trying to see whether we can achieve a functional cure with nukes and other medications, meaning that we cannot get the DNA from the host genome, but we could get rid of the surface antigen loss and patient develop surface antibody. That is called functional cure. One of the studies that was presented at the AASLD meeting was use of interferon early on with nuke to see whether it can improve the surface antigen loss and achieve functional cure. This is a year 5 data. They have presented the previous data multiple times. They have presented their previous data. This was a randomized controlled trial. Patients were randomized to 1-on-1 to either interferon with tenofovir or tenofovir alone. The interferon was given for the first 6 months of treatment. Patients were eligible for retreatment if they had decompensation, either virological relapse or decompensation of liver disease or increase in liver enzyme at any time. This is week 2240 follow-up data. The primary outcome of this was where the addition of interferon can increase the surface antigen loss. The next slide, you will see that there was no increase in surface antigen loss at year 4 or year 5. At year 5, about 4.5% of people on tenofovir alone lost the surface antigen, whereas it was only 5.7 if we added interferon for the first 6 months of the treatment. So this study showed that addition of interferon did not improve surface antigen loss. So we can conclude from this study that there is no role for addition of interferon to nuke to increase the surface antigen loss. So I already alluded to that the DNA of the HPV gets integrated into the host genome very early on after getting infection. A study presented at the same meeting showed that in patients who are transplanted for hepatitis B, you could see the DNA integration into the transplanted liver very early on, and it persisted since then. This study looked at whether long-term tenofovir treatment could decrease the integration of viral DNA into the host genome. So this was a part of a randomized controlled trial. They had paired liver biopsy at the baseline and after 3 years of treatment with tenofovir. 66 patients on tenofovir and 61 patients on placebo had paired liver biopsy. The RNA integration was assessed by RNA sequencing. There was a decline in integration, and there was a correlation between DNA, surface antigen, HPV RNA, and core antigen. More importantly, the bottom panel showed that at year 3, there was a decrease in DNA integration into the host genome. And this was associated with viral load decrease, whether it was with tenofovir or naturally. There was a relationship. So it appears that there was a decrease in the integration, but none of the patients had complete loss of integration, suggesting that the cure of hepatitis B is a long way away. Could we improve the functional cure by additional method? This was examined by a few group of scientists from Japan. They wanted to see whether vaccination for hepatitis B could increase the functional cure. They used a combination of surface antigen and core antigen, and they developed a method to deliver the vaccine nasally. Idea was surface antigen will result in neutralizing antibody, the hepatitis B surface antibody, and core antigen will cause hepatitis B core antigen specific cytotoxic lymphocyte, thereby inhibiting the HPV replication. The vaccination was given 10 times every 2 weeks nasally using a special device. As you can see on the left-hand panel, the surface antigen continued to decline. And they had 2 groups of patients. One, those who had active hepatitis B, chronic hepatitis B, on nuke treatment, and another group who are immune tolerant patients. They were not on any nuke because they didn't require that, they didn't fulfill the criteria for treatment for chronic hepatitis B. So in both groups, chronic active hepatitis group, as well as the immune tolerant phase, there was a decline in surface antigen after vaccination. On the right-hand panel, you can see many patients developed the surface antibody in both groups, those who were treated with the nuke, as well as those who were not on nuke, but because they were immune tolerant. More importantly, there was a mean reduction of surface antigen of 23% at 18 months. and many patients' surface antibody continued to increase. 6 of 72 patients achieved functional cure in a short period. 4 of these patients were asymptomatic carriers. When you look at this panel on the right-hand side, about a third of patients in both chronic hepatitis B group developed surface antibody, and 57% in the immune tolerant group also developed surface antibody. This was very encouraging, suggesting that we may be able to improve the functional cure by this vaccination if it is proven in larger studies. Another technique that was tested was RNA interference agent. And they developed a way to deliver the RNA interference agent to the hepatocyte. They have presented their previous data on healthy subject. This current presentation was on single doses in those with chronic hepatitis B subject, and also multiple doses in chronic hepatitis B dose. They looked at different doses in the phase 2 study. And for the phase part 3, they chose 60 milligram. As you can see on the left-hand panel, single dose, irrespective of the dose, caused a decline in surface antigen. And on the right-hand panel, if they use 60 milligram every 4 weeks, 6 injections were given, and the surface antigen continued to decline. Adverse events were very mild. So in this study, they said an RNA interference agent may cause decline in surface antigen. This needs to be shown in much larger studies. If it is shown, we may have additional way of achieving functional cure in hepatitis B. My final presentation is on hepatitis delta. There is no good treatment for hepatitis delta. Interferon may reduce the DNA, RNA level of hepatitis delta, but it has not achieved the results we have been hoping for. In this study, a group from Washington, D.C. looked at a combination treatment. They used interferon lambda, lonafarnib, and ritonavir. Lonafarnib is a farnesyl transferase inhibitor, or known as prenylation inhibitor. A lipid molecule attached to HTV is important for the interaction of HTV with hepatitis B. This inhibits that integration of the lipid molecule into the HTA. So they used this agent, a combination. Ritonavir was used mainly to increase the levels of lonafarnib. One of the side effects of lonafarnib is GI side effect. By adding ritonavir, they could use a lower dose of lonafarnib to decrease the GI toxicity. They treated this combination for 24 weeks. The lambda was chosen mainly because it is more hepatocyte specific. And they followed the patient for 24 weeks. As you can see in the graph, there was a decline in HTV RNA at week 12, and it was maintained at week 12. More importantly, 50% of these treated patients, it's a small study, had undetectable RNA at the end of treatment. And 23% of them maintained that during the follow-up. This is a very promising study. If it is confirmed in larger study, we may have a possible treatment for hepatitis delta. In summary, I have shown you that addition of PEG interferon to NU did not increase the surface antigen loss. I also showed to you that long-term treatment with NU will reduce the HPV DNA integration into the host genome. 2 molecules I showed you are promising. One vaccine, one an RNA interference agent that may increase the surface antigen loss and thereby functional cure. And also showed a preliminary data on a combination of agents to treat hepatitis delta. Finally, I think it's extremely important for low and middle income countries to adopt and implement universal hepatitis B vaccination. That will reduce the risk of liver disease, risk of transmission in the community, and risk of death from cirrhosis and liver cancer. Thank you.
I must thank Dr. Sudhakar for introducing the speaker, and I also thank Dr. Paul Thuluet for covering the topic of hepatitis B, which is so important still in our part of the world, and giving us a very practical algorithm for the management of hepatitis B. Thank you. You would all agree that we heard 3 excellent talks from the 3 leaders from the various parts of the world. We covered important areas of gastroesophageal reflux disease, hepatitis B, and non-alcoholic steatohepatitis. We have received a number of questions which are there in the chat box, and as promised, you will receive the answers individually through the email. I also thank the 3 chairpersons for introducing the speakers and participating in the meeting.